Good afternoon, everyone. I'd like to thank Dr. Rakesh and the Yashoda Group for the kind invitation. It's absolutely wonderful to be back in Hyderabad again. So in the next 15-20 minutes, I'm going to give you an update on indwelling pleural catheters in pleural effusion. Dr. Fajada has already set the scene quite nicely for me, and there may be a little bit of repetition to start with. So I've got no disclosures or conflicts of interest. So I'm going to talk a little bit about the issues influencing malignant pleural effusion management, optimizing pleurodesis, and then indwelling pleural catheters. So the burden of pleural diseases is rising across the world. We know it's got an abysmal survival. We're doing a lot more radiology, so we're identifying pleural effusions early. People are living longer, and obviously lung cancer screening is on the horizon, so we're going to be seeing more pleural disease. There's been a plethora of studies, as you can see, over the last 10 years on pleural diseases, which is really interesting and has set the scene. I'm going to talk a little bit about these today. So what's the ideal treatment for a malignant pleural effusion? You want to improve breathlessness, quality of life, be minimally invasive, and reduce the length of time in hospital. And the only options we've got are to drain the fluid and seal the pleural cavity. And Dr. Fajada has just mentioned that pleurodesis. So we want to identify who's going to benefit from drainage, who's going to get fluid reoccurrence, who has got a non-expandable or trapped lung, who will benefit from an indwelling pleural catheter versus talc pleurodesis via chest drain, minimize days in hospital, and ensure what's best value for money, because the health economy, depending on where you practice, is important. So there are a number of guidelines now in management of malignant pleural effusion, and the British Thoracic Society guidelines were updated 2 years ago. The ATS recommends an IPC first line if a patient has a re-expandable lung, versus chest drain or talc. And certainly if they've got a trapped lung, then you should go for an indwelling pleural catheter first. And the BTS guidelines are the same. If the patient has a trapped lung, go for an IPC or do a therapeutic aspiration. But if they have an expandable lung, you can do talc pleurodesis via a chest drain or offer them an IPC. It's about patient choice. So pleurodesis requires tight apposition between the viscera and parietal pleura, and it leads to inflammation and decrease in pleural fibrinolytic activity. So what's the best definitive treatment for a malignant pleural effusion? Well, you've got chemical pleurodesis, talc pleurodesis, surgery, and indwelling pleural catheters. And Dr. Fajada has already spoken about the first couple of these. So chemical pleurodesis, we know from this Cochrane review that talc remains the most effective pleurodesis agent. And on this nodal plot, you can see there's been more studies. So the larger the blue circle, the more studies which show evidence for that particular product. So you can see that talc has the most evidence for success. How about what are the determinants of pleurodesis success? So I don't know if some of you, when I was a junior, they used to say, don't give patients non-steroidal anti-inflammatories because it'll reduce the efficacy of pleurodesis. And chest drain size. We use a lot of pigtail or Seldinger chest drains, and are they equally effective at giving talc? So the Time 1 trial was a 2x2 randomized study, randomizing patients to either a 24 French or a 12 French drain, and they were given either non-steroidal anti-inflammatories or opioids. And they looked at their pain scores and pleurodesis success rate at a month and 3 months. They found out that there was no difference with NSAIDs or an opioid, and that perhaps the larger drain was more painful, but perhaps maybe potentially a little bit more effective in pleurodesis. So if you're going to do pleurodesis, you can give NSAIDs. There's no reason not to give them. I know in many parts of the world iodine is used, and the exact mode of action is not clear. And there is a theoretical risk of iodine toxicity, but on some small-scale studies, the efficacy is quite good, but obviously these are small studies which are prone to publication bias. So again, Dr. Fajada mentioned this. Should we do talc poudrage via thoracoscopy or talc slurry? So there's been 2 studies now, the Dressler paper from 2005 and the TAP study in JAMA, which show that if you have a malignant pleural effusion, whether you do thoracoscopic talc poudrage or talc slurry via a chest drain, there's no real difference. So the recommendations are you can use talc slurry or talc poudrage. I personally would say that if you're going to do a thoracoscopy in an undiagnosed pleural effusion where you think malignancy is likely, do your thoracoscopy, get the diagnosis, get the biopsy, and give talc at that time. If a patient is known to have a malignant pleural effusion, and they need it draining and pleurodesing, I would probably just put a chest drain in and give them talc. I wouldn't do a thoracoscopic talc poudrage where the diagnosis is already known. How about surgery? So we've got VATS, talc poudrage, pleurectomy, or pleural ablation. So the MESO-VAT study was a randomized controlled trial looking at partial pleurectomy versus talc pleurodesis in mesothelioma patients, and they found out that there was no difference. So surgical pleurectomy as a pleurodesis for malignant pleural effusion is probably not warranted. There's higher risk of complications, higher risk of hospital stay, and air leak. And the AMPLE-3 trial, which is led by Gary Lee, which is a Southeast Asian Australasian study, I think has just closed, and they are looking at indwelling pleural catheter and talc versus VATS surgery as a pleurodesis. So it'll be interesting to see what those results show. So is an indwelling pleural catheter better than talc slurry pleurodesis? Dr. Fajardo alluded to this just recently. So indwelling pleural catheters have been available in India since 2016, and they've been around for over 25 years. They're silicon-based tunnel catheters or a profibrotic cuff and a one-way valve, which allows vacuum-based fluid to be collected. There are obviously pros and cons. It can be done as a day case procedure. It doesn't require a hospital stay. It empowers the patient. They're in charge of draining their fluid at home, and it avoids repeated procedures. But obviously there are complications. About maintaining an unrestricted lifestyle. There's the aesthetic appearance of it. Not everybody wants a piece of plastic in their chest. And naturally there is a cost, not just of the catheter, but the ongoing drainage. So how about using indwelling pleural catheters as first-line management of a malignant pleural effusion? So there's been two studies, the TIME-2 trial and the AMPLE trial. The TIME-2 was a British study published in JAMA, and the AMPLE was done by Gary Lee's group. And they both randomized patients to either talc slurry via a chest drain or an indwelling pleural catheter first line. And obviously, IPCs was associated with a reduced length of stay, but there's no significant difference in breathlessness or complications. How about in non-expandable or trapped lung? So if the X-ray shows less than 25%, well, if there's greater than 25% of the lung is not opposed, you may suspect someone has a trapped lung. So an IPC is certainly the first treatment you should give in a suspected trapped lung. But it's difficult to tell if someone has a trapped lung. You can see in this X-ray on the right that we put a chest drain in this patient, and you can see the lung did not re-expand. We had no option but to take the drain out and put an IPC in. So you might have told that there are some clues in this X-ray. There's no mediastinal shift. The fluid is tracking all the way apically, so you might think this patient has a trapped lung, but we're quite poor at predicting it. The jury is out on pleural manometry. There are people who are proponents of it and those who support it, but it's still not widely practiced. When you put a chest drain in a patient, in a lung which re-expands, the pressure drops very gradually, as you can see on this green line, as opposed to when you have a trapped lung with a large negative pressure where the pressure drops much more rapidly. And this was evaluated in the pre-EDIT study where they had this manometer which was attached to this aspiration catheter, and they looked at the pleural elastance. If the pleural elastance drop was more than about 15 centimeters of water, patient probably had a trapped lung, but if it was less than 15 centimeters of water, they probably had an expandable lung, and they gave them drain and talc pleurodesis, as you can see here. How about ultrasound? Does that help us predict who may have a trapped lung? So you can see in the middle there is B mode ultrasound, which we use in the majority, and M mode. So if the patient has a reversed hockey stick sign to their lung, they may have a trapped lung. And when you put M mode ultrasound on, you can see normally in a normal lung, the cardiac impulse is transmitted through the lung, giving this sinusoidal sign, which is lost in a trapped lung. Similarly, on B mode, if you see a fishtail sign to the lung, then the lung may re-expand. So if we put an indwelling pleural catheter in a patient with a malignant pleural effusion, if we give talc via the IPC, will it lead to successful pleurodesis? So this was a landmark paper in the New England Journal done by Rahul Bhatnagar's group. So they had patients with a malignant pleural effusion. They drained them on alternate days for 10 days, and then they randomized them, if there was no trapped lung, to saline or sterile talc and followed them up. And they found out that if you gave talc via the IPC following a period of aggressive drainage, you could increase the successful pleurodesis rate twofold. Next question. So again, is IPC better than talc slurry? So if you look at the TAP study, where they gave talc slurry versus talc poudrage, and then IPC via talc, you can see on the right, sorry, I think my slides are not keeping up. Apologies. In the IPC and talc group, at about 7 weeks, the pleurodesis success rate was 55%. Whereas if you gave talc slurry, the pleurodesis success rate at about 7 to 8 weeks was about 80%. So perhaps there is some evidence to say that talc slurry pleurodesis via a drain may still be the best option overall. So I know we've got IPCs out there, we can give talc via the IPC, and people think chest drain and talc slurry, which is the traditional way of doing pleurodesis, is out. It's not the case. There are a number of IPC guidelines out now from the chest group, AABIP as well. So in summary, IPCs, they can be used as first-line therapy and in patients with a recurrent pleural effusion, so I think you need to give the option to patients. You can certainly use them in trapped lung, and you can use manometry and M-mode ultrasound and B-mode ultrasound to predict if someone has a trapped lung. If you give talc via an IPC, you will increase your pleurodesis rate, success rate twofold. You can use an IPC post-thoracoscopy, so you can do a thoracoscopy, put an IPC and give talc and get the patient out. It's a one-stop shop. There's no need for any repeated procedures. I'm afraid drug-eluting IPCs are out. We are not catching up with our cardiology colleagues anytime soon. So this was a study, the SWIFT study looked at silver nitrate impregnated IPCs and whether silver nitrate is a successful pleurodesis agent, but this study looking at normal IPC versus silver nitrate impregnated IPCs was negative. You can use IPCs in non-malignant effusions as well. And this is really exciting. IPC gives you a conduit or an access to the pleural cavity, particularly in mesothelioma. And we've been involved in a phase 1 study in the UK in our center, looking at an agent which we can give intrapleurally for mesothelioma. And an IPC doesn't mean indwelling pleural catheter, but indwelling peritoneal catheter as well. As I said, combined approaches, Chuck Reddy's group in the US looked at thoracoscopic talc poudrage, so thoracoscopy, biopsy, talc poudrage, and IPC. Excuse me. And this was evaluated in the TACTIC trial, which was presented at the Winter BTS in London just in December. So in this study, patients were randomized to thoracoscopy, talc, and IPC versus just thoracoscopy and talc. It's across 11 sites. We participated in this. And it was a study where there was no difference in length of stay, breathlessness scores, or chest pain. And they found that if you are performing a thoracoscopy and you're going to put an IPC in, perhaps it's worth giving talc as well. So in summary, sterile talc remains the most effective pleurodesis agent. Talc slurry via chest drain is still efficient. Maybe a large bore drain might be helpful. You can give NSAIDs. There's no difference in talc pleurodesis success rate, whether you give it thoracoscopically or via a chest drain. Ultrasound can be a predictor of pleurodesis success. IPCs can be given first line, and you can administer talc via the IPC. You should certainly use it for trapped lung. And if you're doing a rapid pleurodesis protocol, perhaps there's no difference in putting an IPC in a thoracoscopy and talc versus doing it alone. But if you are going to put an IPC in a thoracoscopy, give talc. Thank you.
Thank you, sir. If there are any questions, we'll be happy to take them at this time. Thank you, sir. Now we move on from the pleura to the tracheal stenosis. May I call upon on stage Dr. EFFUSION, who will be giving a talk on benign tracheal stenosis and bronchoscopy as a first line of management.